Just a great pleasure now to invite our first speaker, who is Zsuzsanna Varga. You probably know I'm a breast pathologist, so it's a very good that the first speaker is the chair of the breast working group. Zsuzsanna is a world-respected breast pathologist. She works in the Department of Surgical Pathology in the University Hospital in Zurich in Switzerland, and I'm very curious about her presentation. So Zsuzsanna, the podium is yours.
Dear colleagues, dear organization committee, dear participants, I thank you for the invitation for this webinar, and I thank you for the opportunity to give me this opportunity to talk about detection methods in association with the COVID-19 infection. This is the institution where I work. You see here the University of Zurich, and on the left side of the picture, you see the Institute of Pathology and Molecular Pathology where I work. So when you visit us, then you should take this entry to the building. Before we turn to the detection methods in a SARS CoV-2 infection, I would like to pick up two aspects of the disease. One aspect is the spectrum of the infection. We know that most infected patients will have a mild clinical course. It is about 5% of the patients who will get critically ill. These are the patients that will need mechanical ventilation. They get shock disease and complicated with other organs. And we will hear about this later on. The most complicated area is in the respiratory distress syndrome. And another point which is important for the detection, because it has impact on the detection rate, is the stage of the disease. There are 3 stages how this disease is running. First, there is a viral response rate phase followed by a pulmonary phase, turning into a later hyperinflammatory phase. And this is the phase, stage 3, where the most severe symptoms occur. Symptoms as severe respiratory distress, shock, cardiac failure, and so on. And it is very interesting to look at the comorbidities of COVID-19 infection. It doesn't matter if the patient population is coming from China or from New York. The comorbidities that we see in association with COVID-19 are virtually identical. In severe cases, there is an association with chronic obstructive pulmonary disease, diabetes, hypertension, or coronary heart disease. In the study from New York, there was an association with chronic kidney disease, also with obesity, and also with the male gender. So if you put all these factors together, we can consider how we proceed with the detection methodology. This was the first finding that we find in the very severe COVID cases in our institution. On the left side, you see a vessel from a non-COVID patient that is a pathologically normal pulmonary artery. And on the right side, there is an artery from a COVID-19 patient. And you see here, this pulmonary artery is severely inflamed. There are a lot of lymphocytes, plasma cells beneath the endothelium, and also some other cells that are dying through an apoptotic process, as is shown here. And another example, which is important, is the myocardial vessels. We have this section from a patient. There was a clinical suspicion of myocarditis. At this patient, there was no myocarditis at the autopsy. Instead, we could find some scattered lymphocytes beneath the endothelium in terms of a discrete endothelitis. And we know that the virus SARS-CoV-2 can enter the tissues through the AC2 receptors. It is possible to detect AC2 receptors in the tissue with immunochemistry. In this middle picture, you see the same artery as we have seen on the left side. This artery was stained with immunochemistry for AC2. You see here how many endothelial cells express AC2, and a lot of abundant capillaries in the interstitial tissue of the myocard express AC2 receptors. So there are a lot of opportunities for the virus to enter the cells through these receptors. Another example is from the small intestine specimen, which we examined due to intestinal ischemia. You see here these vessels, submucosal vessels, with thrombotic microangiopathy with these leukocytic clots. We noticed that the endothelium shows an increased apoptotic activity at these cases, and this increased apoptotic activity we can demonstrate in immunohistochemistry for cleaved caspase 3 reaction, as is shown also here, and this in the submucosal vessels. The findings that we had in the first severe cases we could publish in Lancet, and the summary of these findings were that this patient had a prominent endothelitis in different organs, including the lung, the small intestine, kidney, myocard, also the liver. And additionally, we could identify disseminated thrombotic microangiopathy with fibrin and leukocytic thrombi. Most prominent, these lesions were in the lung and small intestine. And it's interesting that this apoptotic activity in the endothelial cells were very prominent in the severe cases. We can see here this apoptotic cell death in different arteries and vessels in the lung, as is shown in the caspase cleaved 3 positive immunoreactivity. Shortly after this publication, there was another paper published in Nature Revision Immunology. In this paper, they postulated that this endothelial cell damage that we described morphologically is the main contributor to the initiation and propagation of severe COVID-19 infection. As you see here on this diagram, this diagram illustrates a COVID-positive artery in a pulmonary vessel. All these particles are virus particles. These particles can enter the alveolar epithelium, the endothelial cells, other cells. They can float freely in the alveolar space. The consequence of this viral effect is vascular leakage, hypercoagulation, inflammation, cell death, as described also in details in this paper. And for us in the pathology, that is the point. How can we detect these particles in these cells? It doesn't matter in which organ. Is it free? Is it in some cell structures? They are floating alone? Are they in several areas, and so on? We know it from this paper from the Cell. It was published earlier in April this year, that the virus can indeed enter the endothelial cells. This is the first evidence in blood vessel organoids. You see here a blood vessel organoid infected with COVID-19, with SARS CoV-2 virus, and this organoid is positive for CD31. So it means this organoid is vessel containing the virus, as is shown in the upper part with the positive columns. But this is not what we want in the pathology. We don't want to analyze organoids. We want to have this evidence on the tissue. So what possibilities do we have to have an evidence of the virus in the tissue? We have actually a lot of possibilities. And these possibilities include swabs, RT-PCR, FISH, KISH, immunohistochemistry, fluorescence labeled immunohistochemistry, electron microscopy. And that is the aim of my talk. I would like to talk about the pros and cons and the reliability and the sensitivity of this methodology that is the standard of today. So if we begin the swabs, the smears, they are the classical smears. These smears are used in clinical practice in living patients to see if they are positive or negative. In the pathology, we have a good opportunity to use these swabs in postmortem tissues, especially at cases when there is a suspicion of COVID-19 infection. These smears can be taken from nasopharyngeal area, from lung. We can take it actually from any organ that we want, and we can submit this smear, these swab tissues, to real-time PCR. The result is quick. We have it within a day, and based on the result and based on the logistic of the institution, you can triage your autopsy. It is a very nice paper from Rome, published recently. They made a nice algorithm how you can cope with postmortem swab tissues. If it is negative, you can designate your autopsy as COVID negative and perform it as like this. If it is positive, the appropriate security levels must be met in order to be able to make this autopsy. And this is a picture that you see from our institution. We have a dedicated room for autopsies. A small team is making COVID autopsies in order to protect the rest of the team. And only 3 persons are allowed to stay in the room at the same time. We had very good experiences with swabs during the autopsies. We could confirm negative cases as positive, positive cases as still positive, or something in between. But we have to know the positivity via PCR in the swabs depends on the disease stage. Not all previously positive cases remain positive in the swabs. But this is an examination that we can use in order to triage the autopsies, to find an appropriate room, techniques, and safety regulation depending on the own institution. What about RT-PCR in paraffin-embedded formalin-fixed tissues? It is an easy methodology. We can integrate it in the diagnostic, and that is possible to perform in postmortem or in biopsy tissues. We have to know that the methodology is highly sensitive. Even a very small amount of viral load can be amplified with RT-PCR in FFPE tissues. The advantage of this method is that we can make an organ involvement. We can assess how many organs are positive if you make it in autopsies or in different tissues. But we have to be aware that false negative or rarely false positive cases can occur. This first study from Hamburg analyzed 22 cases, autopsy cases, using RT-PCR, and they could confirm a broad organ involvement through the SARS CoV-2 infection in different organs. So basically, this study confirmed with the RT-PCR the results that we described previously based on the morphology. What about in situ hybridization on formalin-fixed paraffin-embedded tissues? If this technique works, then it is fantastic because we have a signal. This signal is cell type specific. We can say exactly which cell is positive, where we see the results. So we can localize the signals. We can say endothel, epithel, stroma, whatever cells are positive. We have to be aware of the caveats. This reaction is fixation sensitive. If the specimen is staying too long in formalin, it can eliminate the virus, and the laboratory procedures are demanding. So these very nice pictures that were published recently show nice examples of in situ hybridization for SARS CoV-2. These are very nice reactions. In our institution, we did not have that much luck. We had until now no possibility to detect any virus in the specimens that we made. So I think it is on the way to get a better technology. I'm coming to the question of immunohistochemistry or with immunofluorescence labeled immunohistochemistry. That would be actually the ideal methodology for all pathologists because this is what we do every day. We know how it works, the laboratories know how it works, and we could localize the stain intensity to a specific cell type. Postmortem and biopsy tissues are both appropriate for this diagnostic. We can make an organ involvement, as I mentioned, cell type specific signals can be really localized with an immunohistochemy. The problem that I see at the moment is that many pathology institutions face unspecific background stain and unspecific stains. These very nice stainings that were recently published are really nice, and if it is working like this, it's good. It doesn't work like this in many institutions. We tried several clones to get such nice and reliable signals. We are at the moment not at that space, at that step where we can say we have a good antibody, where we have reliable signals. There is another approach here that is also from the previously mentioned group from Hamburg. They made immunohistochemistry labeled with fluorescence secondary antibody, and you can see here in these kidney samples, this fluorescence labeled immunohistochemy worked very well on paraffin embedded tissues. The same group from Maryland published these nice papers, and this is also a very nice example of immunofluorescence labeled immunohistochemistry on pellets. These pellets were fixed in formalin, and what you see here is this combined immunofluorescence labeled immunohistochemistry labels the spikes protein labeled with green and also the neurocapsid protein labeled with red. So if we get it with the technique, that is a good technology. I think the technology is really demanding. And here you see immunohistochemistry stains on pellets. I think if the laboratory gets these signals, it's good. Many laboratories struggle with these signals. we tried in our own institution the same antibody as was published in this Maryland paper. We used the same immunohistochemy against the spike component of the virus, and we used frozen tissues from autopsy cases. And from frozen tissues with autopsy cases, we succeeded in reliable signals with some amplification kit we had to use for this reaction. But you see here some endothelial cells, also some tubular epithelial cells showing positivity for the spikes component of the virus. And here also in the lung alveolar epithelium, we see these shining signals that corresponds to viral particles. We are not at the step in our institution to use this technology on paraffin embedded material, but we are working on this, that we get those signals also on paraffin material. Electron microscopy. This is an interesting topic which I would like to address. When I saw this picture from the first Korean patient earlier this year, I thought it is very easy to detect viral particles using an electron microscopic stain. Here you see this classical, very easily detectable viral particles with this spiked ring around, being alone or covered in a bound vesicle. At the time, I think many pathologists who use this methodology recognized that the identification of exact viral particles using electron microscopy is more complex than we originally thought at the beginning of the pandemics. The technology of electron microscopy to detect virus is demanding, time-consuming, and searching for virus takes sometimes several hours. It also needs good expertise in ultrastructure. Most cases are autolytic, have fixation artifacts. We have to deal with this fixation artifact, also with the fact that due to these artifacts, sometimes there are no viral particles at all in the cases. We have to avoid interpretation errors, and especially we have to recognize mimics in ultrastructure. Vesicles can mimic viral particles, so we have to be sure what we are seeing. And it is not always easy to see it in an autopsy tissue. And we have to say that the definitive evidence for viral particles on the ultrastructural level needs an immunoelectron microscopy, which is even a more complicated procedure than the EM analysis itself. But last but not least, the electron microscopy is a useful methodology because we learn a lot from this. In this, since the pandemic began, there were some papers, pathology-based papers using biopsy and autopsy tissues. And in these papers, including our papers, there was a range of viral-like particles that were described in association with SARS CoV-2 infection. These particles that were described in different papers have similarities, but also dissimilarities. They vary in the size, also in the form. So to say definitely which are specific for a SARS-CoV-2 infection and which particles are just seen within this infection needs further studies and also immunoelectron microscopy on the same section. But the electron microscopy is a useful method also for other questions. In this paper recently published from the pathology in Hamburg, they have analyzed vasculature in the lung, and they have, you see here these fantastic pictures with these disturbed vascular channels in the lung. And this picture is very interesting here in the lower row. These vascular channels have some disruptions here, possibly representing an entry to the virus. It is a hypothesis, needs to be proven, but these pictures maybe give us further clues how the virus gets into the tissue at all. And with this slide, I'm coming to my summary. I would like to show you here how many methodologies we have. And we have here pros and contras. We have here different sensitivities and reliabilities regarding these tissues. The highest sensitivity we could reach with the swabs and with RT-PCR in formalin fixed tissue, although these results say the tissue is positive. We don't know which cell exactly is positive, and the specificity, especially at the swabs, depend on the stage of the disease. Other methodologies as FISH, KISH, immunohistochemistry, fluorescence labeled immunohistochemistry, electron microscopy have a lower sensitivity. They can be done in one day, or it can last a little bit longer. Advantage of this technology would be as specificity. We can localize the stains. Disadvantage is today is that we face with background stains, unequivocal signals. So the reliability and the specificity of these methodologies need more improvement and more patience from our side. And with that slide, I come to the end. I thank you very much for your attention.